Devesh Bhatt, and today we are gonna discuss two topics. The first one is gonna be visual pathway fields and the lesions of the pathway, and the second one is gonna be pupillary light reflex pathway and its defect. So let's get started with the simple concept of the image that is formed on retina is going to be real and inverted. And what does real and inverted image means? Let me give you an example. So for example, whenever light rays are refracted on any lens that is convex shaped, the light rays are gonna be refracted and they'll focus behind the lens and form an image which is real and inverted. As you can appreciate here, the giraffe, the head here is at the down, the legs are up. So basically नीचे का ऊपर हो गया है, ऊपर का नीचे हो गया है, left का right हो गया है, right का left हो गया है, just like our life. But that is how the image is formed on retina. So talking in a very Gen Z lingo, the image that is formed on retina is gonna be inverted and flipped. It is going to be inverted and flipped. All right. So for example, let's close your right eye. Now you are only able to see from your left eye. So the box that you are seeing right now from your left eye is going to be your left eye ka visual field. This is going to be your left eye ka visual field, and the image that the visual field is, which is gonna project on your retina, is gonna be like this. So this is your left eye ka retina. As we have taken the example of left eye, we are gonna have the nose over here. This is gonna be our nose, and the part which is the half part which is nearer to the nose, we are gonna term it as nasal, and the other half which is towards the temporal side, we are gonna term it as temporal. Same, we gonna give the same terminology to the visual field as well, but also it is also divided into superior and inferior. So the part towards the nose which is superior is gonna be termed as superior nasal. The part which is inferior and towards the nose is gonna be termed as inferior nasal. The part which is superior and outside is gonna be towards the pie in the sky is gonna be superior temporal, and the one which is inferior downwards, looking downwards and outwards, is inferior nasal. I mean inferior temporal, because it's the temporal side. Sorry, that's my mistake. All right. So now what is gonna happen, as I told, that the temporal part of the visual field is gonna project itself on the nasal side of the retina, and the nasal part of the visual field is gonna project itself on the temporal part of the retina, just like this. It's gonna be flipped and it's gonna be inverted. That means that the superior part of the visual field is gonna project itself on the inferior part of the retina, and the inferior part of the visual field is gonna project itself on the superior part of the retina. And this concept will be helpful when we are talking more in detail about the visual field defects. So let's start and let's study visual field pathway. So we have our left eye, we have our right eye, and in the middle obviously we have our nose. And as I told, the half part towards the nose, we will call it as nasal, and from the nasal side obviously we are going to have nasal fibers, and the part which is outside is the temporal part, and obviously from the temporal side we are going to have temporal fibers. And this two red and green that you are seeing right now, this is the visual field of the left eye, this is the visual field of the right eye, and as I have explained earlier, this is how it is gonna project itself on the retina. So let's see once more and let's understand this concept अच्छे से. So here from the left eye, this is the temporal side of the visual field of the left eye. It is gonna project its light here on the nasal aspect of the left eye. The nasal part of the left eye, the nasal part of the visual field of the left eye is gonna project itself on the temporal side of the left eye. Same with the right eye too. Let's see. The nasal side is gonna project itself on the temporal side. The temporal side of the right eye is gonna project itself on the nasal side of the right eye. All right. So from here on, it is going to be the responsibility of the optic nerve to take the information and give it to the brain. And one important thing that happens to the optic nerve is it decussates and it forms a chiasma, and it is very important for us to know that what fibers cross and what fiber doesn't. So the temporal fibers of both the eyes doesn't cross. It is only the nasal fibers of both the eyes that are gonna cross, that are gonna decussate and form a chiasma, that we call it as optic chiasma. All right, so let's see with this diagram here is that the temporal fibers of the left eye, it is not gonna cross. The temporal fibers of the right eye, they are not gonna cross, but it is only the nasal fibers here. The fiber from the left nasal fiber is gonna cross like this and go to the right side. Here on the right eye, the right nasal fibers are gonna cross and go towards the left side. Now if you observe that the right side, the right optic tract, this forms the right optic tract, right? The right optic tract has the information of left visual fields of both the eyes. See, if you see the red color, if you follow the red color, it is having the information of the left side. It is having the information of the left side of both the visual fields of the left eye and right eye. है ना? So now, if you have a lesion which is cutting the optic tract, you are gonna have a loss of vision of the left side of both the visual fields. So how we gonna name it? It is going to be contralateral, because the lesion is in the right eye, but the vision you are losing is from the left side. So it is contralateral. It is homonymous. That means it is the left side of both. It is the left visual fields of both the eyes. That is the left eye and the right eye. They are losing the same visual field. That is the left visual field. So it is homonymous. It is hemi, that is only half of the vision is lost, and anopia मतलब कुछ दिख नहीं रहा है. And this is the same concept behind, which is associated with Wernicke's hemi and opic pupil, and this is the same concept we are also again going to discuss in the same pathology further in the video. All right, so let's discuss more pathologies. Let's discuss more lesions. So one more lesion that is more commonly asked always in the exam is what happens if there is a tumor that is pressing on the optic chiasma. As I told, optic chiasma contains fibers from the nasal part of both the eyes because they decussate, and the nasal part of both the eye are having the projection from the temporal fields of the visual field of both the eyes, and hence the name says it is gonna have by temporal means temporal visual fields of both the eyes. हेमी मीन्स आधा, सिर्फ आधा ही गया है, नेजल वाला पार्ट दिख रहा है. एनोपिया मतलब आधा नहीं दिख रहा है. फॉर एग्जाम्पल यहाँ पे देख लो, इफ दिस वॉज विजुअल फील्ड, यहाँ पे यू कांट सी द टेम्पोरल साइड ऑफ द लेफ्ट साइड ऑफ द लेफ्ट आई ऑफ द लेफ्ट विजुअल फील्ड. यहाँ पे राइट विजुअल फील्ड है, इसका भी टेम्पोरल साइड नहीं दिख रहा है. दैट मीन्स बाय टेम्पोरल दोनों साइड का टेम्पोरल नहीं दिख रहा है. Hemianopia, which is seen when there is a tumor which is pressing on the optic chiasma. All right, so this lesion, when there is a lesion on the optic nerve directly, ये तो बहुत सिंपल है क्योंकि ऑब्वियसली अब ऑप्टिक नर्व ही सीधा चला गया तो इप्सिलेटरल आई का ही पूरा एक विजन चला जाने वाला है. सो इफ देयर इज अ लीजन ऑफ राइट ऑप्टिक नर्व, obviously right side का vision चला जाएगा. When we have optic chiasma, something pressing on the optic chiasma, we are gonna have loss of bitemporal visual fields. Now when we have right optic tract, that is we have the right optic tract which is damaged, we are gonna have contralateral loss of vision. All right, so यहाँ तक easy था. Now we are gonna discuss the concept of superior quadrant anopia and inferior quadrant anopia. All right, so to explain this, I'm gonna go back to this same diagram in which I have explained you. So मैंने क्या कहा था कि ये जो superior temporal field है, it is gonna पहले तो लेफ्ट का राइट हो जाएगा, ठीक है, तो टेम्पोरल का नीजल पार्ट पे चला जाएगा और ऊपर का नीचे चला जाएगा. सो द सुपीरियर टेम्पोरल फील्ड is projected to the inferior nasal fibers और inferior nasal quadrant of the retina, और यहाँ से inferior nasal fibers ये इंफॉर्मेशन लेके चले जाएंगे और ये फाइबर्स का नाम हम देंगे मेयर्स लूप. ठीक है, एंड मेयर्स लूप विल गो एंड रिले द इंफॉर्मेशन टू द टेम्पोरल लोब. एंड द इंफीरियर टेम्पोरल क्वाड्रंट वो अपना प्रोजेक्शन कहाँ देगा? वो अपना प्रोजेक्शन देगा टू द सुपीरियर नेजल क्वाड्रंट ऑफ द रेटिना, और यहाँ से निकलते हैं सुपीरियर फाइबर्स, और इन फाइबर्स का हम नाम देते हैं बॉम्स लूप, एंड ये जाते हैं पैराइटल लोब में. और इसको आप है ना ब्रेन के एनाटॉमी के साथ भी कोरिलेट कर सकते हो. यहाँ पे देखो, पैराइटल लोब इज एनाटॉमिकली सुपीरियर, है ना, और बॉम्स लूप आर सुपीरियर फाइबर्स एंड देल गो, सुपीरियर फाइबर्स है ना, तो जाएंगे पैराइटल लोब में. और टेम्पोरल लोब इज एनाटॉमिकली इंफीरियर, तो ऑब्वियसली जो इंफीरियर फाइबर्स है वो जाएंगे टेम्पोरल लोब में, और इंफीरियर फाइबर्स का नाम है मेयर्स लूप और सुपीरियर फाइबर्स का नाम है बॉम्स लूप. और मेयर्स लूप में अगर डैमेज है देन इट इज़ गोना गिव यू अपीयरेंस ऑफ पाई इन द स्काई. ठीक है, और अगर बॉम्स लूप में कोई डिफेक्ट है देन इट इज़ गोना बी इंफीरियर क्वाड्रेंट एनोपिया. आई होप दिस इज क्लियर. ठीक है, लाइक दिस. Inferior quadrant anopia is because of Bohm's loop, and superior quadrant anopia, it is because of the inferior fibers which are the Meyers's loop, which is also known as pie in the sky. ठीक है, अब now if you have a kind of visual field loss which is homonymous, यहाँ पे देखो सेम साइड अफेक्टेड है, that's why we will call this as homonymous, but macula is paired. Why macula is paired? क्योंकि मैक्यूला हैज़ ड्यूअल ब्लड सप्लाई. इट इज़ सप्लाइड बाय पोस्टीरियर सेरेब्रल एंड मिडल सेरेब्रल आर्टरी. सो इफ वी हैव एन इस्केमिक स्ट्रोक ऑफ द पोस्टीरियर सेरेब्रल आर्टरी इन विजुअल कॉर्टेक्स, तो हमको होमोनिमस हेमिएनोपिया तो मिल जाएगा, बट मैक्यूला स्पेयर हो जाएगा बिकॉज मैक्यूला हैज़ ड्यूअल ब्लड सप्लाई, because it is supplied by MCA and PCA. So the seventh lesion, if there is an ocular trauma which is directly hitting to the macula, then we are gonna have macular lesion और सिर्फ macula का vision loss होगा. And I hope this way I'm able to cover all the visual field defects in a simpler and easy way. And let's go to our second topic of the day that we are gonna discuss, which is pupillary light reflex and its pathway. Going further to the pupillary light reflex pathway, I would also like to add one little point that and some extra edge information that, you know, near the optic chiasma on the temporal side, on both the sides here, we have our carotid artery that is running. So by chance, very rarely, if there is a bilateral carotid artery tumor, right, so it is gonna press on the bilateral temporal sides press होने वाली है, temporal fibers press होने वाले हैं, and the temporal fibers are gonna take information and take projection of light from the nasal side of both the visual fields. So in case of bilateral carotid artery tumor, we are gonna have a finding which is known as binasal hemianopia. So with this, let's proceed to our second topic of the day, which is the pupillary light reflex pathway. And let's start with the basics again here, that what causes the pupil to dilate and what causes the pupil to constrict. So the constriction and dilation of pupil is under the control of parasympathetic and sympathetic system. As you can see that parasympathetic constricts because it has concentric rings. The muscle is like concentric rings, also known as constrictor pupillae, and sympathetic system will dilate the pupil because the muscles are radially arranged like this, which are known as dilator pupillae. Okay, all right. So let's start with the visual field. Let's start with the pupillary light reflex pathway. All right. So now, when you have excess of light that is falling onto your eye wants to protect your retina, and that's why it will constrict your pupil. So let's take the example of the left eye here. You have the light rays coming and falling onto your retina. The information will be taken by the optic nerve, alright, and then the optic tract, and the optic tract will go up till pretectal nucleus, and from here the pretectal nucleus will give information, will pass on the information to the Edinger-Westphal nucleus of both the sides of even the opposite eye. Here's the catch, guys, that the pretectal nucleus will pass on the stimulus to the Edinger-Westphal nucleus of both the sides of left and right. Even though the light is just falling on the left eye, it is gonna give the information to the Edinger-Westphal nucleus of both the sides, and we know that Edinger-Westphal nucleus is a home to third cranial nerve. And as from anatomy, we know 3, 7, 9, 10 are the cranial nerves which are parasympathetic. So from Edinger-Westphal nucleus we will have this third cranial nerve which will go on both the sides, because the pretectal nucleus has stimulated the Edinger-Westphal nucleus of both the sides. Here there will be a ciliary ganglion, and it will stimulate short ciliary nerve, which is a parasympathetic nerve, which will go to constrictor pupillae muscle, and it will constrict both the eyes. So in a normal eye, if you cover one eye, if I am covering one eye and I am putting torch on the other eye which is open, I'm gonna have pupils that will be constricted and in both the eyes, and this is a normal physiology. So on the basis of this concept that we have learned, all right, so there will be different defects that we are gonna discuss. So here this pathway is divided into two parts. One is efferent part and one is efferent part. Efferent part is the part that from here optic nerve, optic tract, and up till the pretectal nucleus, it's the efferent part. Efferent means absorb करना, sensory information को लेना is the efferent part. And efferent part, efferent means अब हमको पता लगा है कि लाइट पहुंच चुकी है, हमको प्यूपिल कॉन्स्ट्रिक्ट करना है. So that information कि हमको प्यूपिल कॉन्स्ट्रिक्ट करना है टू द मसल कि हाँ चलो अब हम कॉन्स्ट्रिक्ट होते हैं, वो जो पाथ है वो इफेरेंट पाथ होगा. सो फ्रॉम द एडिंगर-वेस्टफल न्यूक्लियस टू द थर्ड क्रेनियल नर्व टू द शॉर्ट सिलियरी नर्व, ये पूरा पाथ इफेरेंट पाथ होगा. एंड नाउ वी आर गोना डिस्कस डिफेक्ट्स ऑफ द डिसीजेस that are gonna cause efferent defect, and we are gonna discuss diseases that are gonna cause efferent defect. As I told that if you are showing light in one eye, normally your both the eyes are gonna constrict. So if there is an efferent defect of one eye, of the defective eye, obviously बात है कि दोनों आई कंस्ट्रिक्ट नहीं कर पाएगी if you are showing the light in a defective eye. So whenever there is a lesion which has an efferent defect, and what is the efferent pathway? The efferent pathway goes from optic nerve to the optic tract to the pretectal nucleus, है ना. तो अगर ये pathway में कोई भी defect है, then there will be defect in both the eyes, and it will be called isochoria because it is same, it is bilateral symmetrical. And सब हर डिजीज में ऐसा नहीं होता. इन मोस्ट ऑफ द डिजीज which causes defect in the efferent pathway, most of the times it is going to be isochoria, also known as it is going to be a symmetrical defect. ठीक है. It is also known as absolute efferent, total efferent, pupillary defect. ठीक है. And the examples of them are Marcus gun pupil, also known as RAPD. It is known as relatively efferent pupillary defect. Wernicke's hemianopic pupil, and Argyll Robertson pupil, which is example of asymmetrical एसिमेट्रिकल एफरेंट डिफेक्ट, ठीक है. Now talking about efferent defect. Now what is the efferent path? I told from the Edinger-Westphal nucleus to the third cranial nerve to the ciliary ganglion and to the short ciliary nerve, which is a parasympathetic nerve. अगर ये pathway के बीच में कोई भी defect है, then it is gonna be an asymmetric defect, also known as anisocoria, because the information from the pretectal nucleus has already been passed टू द एडिंगर वेस्फल न्यूक्लियस, ठीक है. तो अगर उसके आगे कोई भी डिफेक्ट है तो ऑब्वियसली वो इप्सिलेटरल होने वाला है और वो इस एसिमेट्रिक होने वाला है. एंड सम ऑफ द एग्जांपल्स आर एडिस्टोनिक प्यूपिल, हॉर्नर सिंड्रोम एंड हचिंसन प्यूपिल दैट वी आर गोना स्टडी इन डिटेल. First disease of the efferent pathway, which is Marcus-Gunn pupil, also known as relative efferent pupillary defect. As the name suggests, it is the defect in the efferent pathway. So as I told, चलो let's take example, ठीक है. ये है नॉर्मल आई जिसको हम येलो कलर से हाईलाइट कर रहे हैं, ठीक है. अगर नॉर्मल आई में हम लाइट दे रहे हैं, सो इट इज गोना टेक द इंफॉर्मेशन टू ऑप्टिक नर्व, ऑप्टिक कायस्मा, ऑप्टिक ट्रैक टू द प्रीटेक्टल न्यूक्लियस. प्रीटेक्टल न्यूक्लियस क्या करेगा? एडिंगर वेस्फाल न्यूक्लियस को इन्फॉर्मेशन दे देगा दोनों साइड के. एडिंगर वेस्फाल न्यूक्लियस क्या करेंगे? वो जाएंगे, ये आई को भी कॉन्ट्रैक्ट करेंगे, लेफ्ट आई को भी कॉन्ट्रैक्ट करेंगे और राइट आई को भी कॉन्ट्रैक्ट करेंगे. नाउ व्हाट विल हैपन इफ फॉर एग्जांपल वी हैव दिस राइट आई विच इज आई मीन, चलो यहाँ पे डिफेक्ट कहाँ पे है? चलो मान लेते हैं कि यहाँ पे ऑप्टिक नर्व में डिफेक्ट है, यहाँ पे ऑप्टिक नर्व में डिफेक्ट है. सो नाउ वी आर showing our light to the right eye. Left eye is covered. We are showing our light to the right eye. वो क्या होगा? जा ही नहीं पाएगा ना, क्योंकि ऑप्टिक नर्व डैमेज्ड है. ऑप्टिक नर्व डैमेज्ड है, वो जा नहीं पाएगा. तो यहाँ से ऑप्टिक नर्व से प्रीटेक्टल न्यूक्लियाई पे सिग्नल नहीं पहुंचेगा. अगर प्रीटेक्टल न्यूक्लियाई पे सिग्नल नहीं पहुंचेगा तो वो एडिंगर वेस्फाल न्यूक्लियस को कैसे सिग्नल देगा? नहीं दे पाएगा. सो राइट आई में, राइट ऑप्टिक नर्व में डैमेज है, राइट ऑप्टिक नर्व में डैमेज है, बट लेफ्ट आई भी कंस्ट्रिक्ट नहीं कर पाएगी. एंड दिस इज द कॉन्सेप्ट बिहाइंड मार्कस गन प्यूपिल, ऑल्सो नोन एज रिलेटिव एफेरेंट प्यूपिलरी डिफेक्ट. और it is most commonly associated with multiple sclerosis because multiple sclerosis causes optic neuritis. So in exam there could be a case scenario which is telling you about relative efferent pupillary defect, and then in the options you have to find if it is multiple sclerosis, or it could be vice versa. There could be a scenario, there could be a clinical scenario in the question which is giving you signs and symptoms of multiple sclerosis, like cognition defective हो गया है, numbness हो रहा है, tingling हो रहा है, all the symptoms of multiple sclerosis. And then they will ask you which pupillary defect will be seen, and then you have to mark relative efferent pupillary defect. और उसको डायग्नोस करने के लिए there is a test known as swinging flashlight test which we perform. उसमें क्या होगा? फॉर एग्जाम्पल मैं अपनी राइट आई इज नॉर्मल, द राइट साइड इज नॉर्मल, द राइट ऑप्टिक नर्व इज नॉर्मल, ऑलराइट. सो इफ I throw the light on the right side of my eye, both the pupils are gonna constrict equally. Now I'll swing the light to the left side. Now the left side is defective, the left optic nerve is defective. Because it is defective, the left side तो constrict होगा ही नहीं, right side भी नहीं होगा. So this is relative efferent pupillary defect, alright. और ऐसा सेम कॉन्सेप्ट होता है ब्लाइंड आई में. फॉर एग्जाम्पल चलो मान लेते हैं सेम कॉन्सेप्ट ऐसा होता है ब्लाइंड आई में. इफ वी हैव इंटैक्ट सिंपैथेटिक एंड पैरासिम्पैथेटिक कनेक्शंस ऑफ द आई. फॉर एग्जाम्पल वी हैव द लेफ्ट आई, ग्रीन कलर है, इट इज़ नॉर्मल, लेफ्ट आई नॉर्मल है. अगर तुम लेफ्ट आई में लाइट थ्रो कर रहे हो, ऑलराइट, सेम द पाथवे दैट वी फॉलो, ऑप्टिक नर्व, ऑप्टिक ट्रैक, प्रीट्रैक्टल न्यूक्लियस, वो एडिंगर वेस्फाल न्यूक्लियस को इन्फॉर्मेशन देगा दोनों साइड, और दोनों साइड कंस्ट्रिक्ट हो जाएगी. ध्यान रखना, इवन राइट आई विल बी कंस्ट्रिक्टेड, क्योंकि थर्ड क्रेनियल नर्व तो इंटैक्ट है, मसल्स इंटैक्ट है, विजन में प्रॉब्लम है ना, ठीक है. अब फॉर एग्जाम्पल ये राइट आई इज ब्लाइंड, वो ब्लाइंड आई है. अब यू आर थ्रोइंग योर लाइट हियर, आगे बढ़ने ही नहीं वाला है, ऑप्टिक नर्व पे इंफॉर्मेशन जाएगी नहीं, ऑप्टिक ट्रैक पे नहीं जाएगा, प्रीटेक्टल न्यूक्लियाई पे नहीं जाएगा. सो इफ यू आर थ्रोइंग द लाइट ऑन द राइट साइड, the right side will not constrict, even the left side will not constrict. And this is the same concept like Marcus gun pupil. ऐसा blind eye में भी होता है if and only there is intact sympathetic and parasympathetic innervation, वो intact होना चाहिए. Alright. So now we are talking about a condition where optic tract is involved, and the name is Wernicke's hemianopic pupil. So for example, we are taking the optic tract, the right optic tract. If it is lesioned, if the right optic tract is lesioned, now from here on we are going to go retrospectively and see what fibers are affected. So as I told that the temporal fibers don't decussate. So we will be having temporal fibers from the same side, that is the temporal fibers of the right eye, because the right optic tract is involved, and the nasal fibers are the one that are going to cross over. So we will be having nasal fibers of the left eye that will be coming and crossing over and going to the right optic tract. So now we have to perform, now we want to perform the light reflex test. But the thing is, half part of the retina on both the eyes is not functioning well and won't be taking that stimulus of light because the right optic tract is injured or is lesioned. So if we are throwing light in such a way, so let's talk about the same eye first, because on the same eye, the temporal side of the retina is affected. So if we are throwing light in such a way like this, which is falling on the temporal part of the right eye, the pupillary light reflex is going to be absent. And on the opposite side, if we are throwing light in such a way that it is falling on the nasal retina of the left eye, the pupillary light reflex is going to be absent. But the other part of the retina is normal. So for example, if there is a lesion of right optic tract, and if we are throwing light in such a way on the left eye that it is falling on the temporal retina of the left eye, then we are going to have positive pupillary reflex. In the same way, the nasal part of the right eye is also normal. So if we are throwing light in such a way that it is falling on the nasal retina of the right eye, in the condition where right optic tract is lesioned, as I told that nasal fibers are the one that decussates and goes to the other side, we are going to have positive pupillary reflex. And this chart says the same thing, that when we are throwing light in such a way, all right, in what conditions the light reflex will be absent? If on the same side, that is if the lesion is on the right optic tract, you are throwing the light on the temporal retina, the light reflex will be absent. If on the opposite eye you are throwing the light on the nasal retina, the light reflex will be absent. And if you are throwing light in such a way for example, if the lesion is on the right optic tract, if you are throwing light on the same eye in the nasal retina, that is right nasal retina, then the pupillary light reflex will be present. And on the opposite eye, that is the left eye, if you are throwing light on the temporal retina, the light reflex will be present. Talking about a condition where mostly the patients of tertiary neurosyphilis are going to present as Argyll-Robertson pupils, and the main pathology behind such pupil is they are having the lesion in pretectal nucleus. And also Argyll-Robertson pupil is an example of asymmetric anisocoria. That means the left and the right pupil both are asymmetrically constricted. All right, so they'll be presenting with bilateral meiosis, that is the contracted pupil. And also such kind of pupils dilate very poorly with mydriatics. Okay, all right, and there is an easy way to remember what actually happens in Argyll-Robertson pupil. ARP, that means accommodation reflex is present, while PRA, pupillary reflex is absent. ARP, accommodation reflex present. And to understand the reason behind why such thing is happening, let's come back here to this diagram. We were having our optic nerve, which were taking the information from our lovely retina, we have this our lovely optic nerve going to the optic tract, and this optic tract is giving its signal to the pretectal nucleus, which is over here. If we have defective pretectal nucleus, there will be obviously there won't be any light reflex, because pretectal nucleus is the one which gives signal to both the Edinger-Westphal nucleus. And why it is asymmetric and isochoric? Because both the pretectal nucleus are being affected, all right, but obviously both of the nucleus won't be affected symmetrically. One of the nucleus might be having more damage, the other nucleus might be having less damage, and this is the reason behind asymmetric anisocoria. And now you must be wondering, then why accommodation reflex is present? What is accommodation reflex? So basically, accommodation reflex means near light dissociation. So what happens when you converge your eye, like this? What happens? The medial muscles known as medial rectus of both the eyes are being activated, and they help both of your eyes to converge in this direction and bring a focus. When you want to focus on something which is very near, your eyes will converge, and this is known as accommodation. And it is because of a muscle known as medial rectus. And if you know from anatomy, or if you know from optha, if you read it, that LR6SO4 lateral rectus is supplied by 6th nerve, SO4 superior oblique is supplied by the 4th cranial nerve, and rest all the other muscles are supplied by the 3rd cranial nerve. And also 3rd cranial nerve was the parasympathetic nerve, all right, which was arising from Edinger-Westphal nucleus, which was responsible for doing meiosis. And that's why, because medial rectus, because here in this condition only pretectal nuclei is affected, the Edinger-Westphal nucleus, and the path thereafter is completely normal. The Edinger-Westphal nucleus is completely normal. And now when you want to accommodate, you will bring both the eyes at one point. Medial rectus will be activated, cranial nerve number 3 will be activated, and then your eyes will converge, obviously. But along with that, the function of 3rd cranial nerve is to see where the 3rd cranial nerve is going. This is the Edinger-Westphal nucleus. The 3rd cranial nerve here is going to the short ciliary nerve. Here it's a ciliary ganglion, and on ciliary ganglion it will supply to the short ciliary nerve, which will indeed constrict your pupil. And that's why in condition of Argyll-Robertson pupil, you have accommodation reflex that is present. So while accommodating your eyes, your pupils will constrict more. But while if you show a light to the pupil directly, the pupillary light reflex will be absent. And a beautiful concept, right? So let's go on to the next condition of adistonic pupil. Charged up, people will say that you are toned up. So is with pupil. So when the pupil is sympathetically charged up, we will call it as tonic pupil, also known as adistonic pupil, also known as Homer eddy pupil. So what basically is happening, and usually it is associated with diabetes, viral infection, or maybe orbital trauma. So the patient here is presenting to you with regular mildly dilated pupils of around 4 to 6 mm. And here the light reflex here is absent. And why the light reflex is absent? Because it is said that in adistonic pupil the damage is at the level of short ciliary nerve or ciliary ganglion. It is said that it is because of the denervation in the postganglionic nerve. So let's see here in the map itself कि कहाँ पे है अपना short ciliary nerve, कहाँ पे था अपना short ciliary nerve, यहाँ पे था. अगर पूरा पाथवे ठीक है पर अगर शॉर्ट सिलियरी नर्व ही खराब है तो ये प्यूपिल कॉन्स्ट्रिक्ट कैसे होगा? और अगर बायलेटरली शॉर्ट सिलियरी नर्व इंजर्ड हो गया है या तो फिर काम नहीं कर रहा है, तो ऑब्वियसली द पैरासिम्पैथेटिक वोंट वर्क, क्योंकि पैरासिम्पैथेटिक का काम क्या था? प्यूपिल को कॉन्स्ट्रिक्ट करना. इफ द प्यूपिल इज नॉट गेटिंग द पैरासिम्पैथेटिक सप्लाई, कॉन्स्टेंट पैरासिम्पैथेटिक सप्लाई नहीं मिल रहा है अगर प्यूपिल को, देन क्या होगा? प्यूपिल विल ऑब्वियसली डायलेट. और एडिस्टोनिक प्यूपिल में यही हो रहा है, बिकॉज शॉर्ट सिलियरी नर्व इज डैमेज, द पैरासिम्पैथेटिक, द शॉर्ट सिलियरी नर्व इज डैमेज, it is not able to cause meiosis, and that's why the sympathetic activity takes over. The sympathetic nerve supplies to the muscle called dilator iridis, which cause mydriasis, which is known as dilation of pupil. और ये जो मसल है dilator iridis वो रेडियली ऐसे अरेंज्ड होते हैं एंड इट इज़ नोन टू कॉज डायलेशन ऑफ द प्यूपिल, है ना. ऑलराइट, सो what are the other things that are related to eddy-stonic pupil? That the pupil will constrict with 0.125% pilocarpine. Why does that happen? Because since such a long time pupil was deprived of the parasympathetic supply, है ना. उसको सिर्फ sympathetic supply मिल रहा था and parasympathetic system is also known as cholinergic system. तो मतलब इतने सालों से अगर आपको खाना ना दे और आपको तुरंत कुछ एकदम अभी तो गर्मियों का सीजन है तो कोई आपको आम रस और पूरी दे दे तो आप तो टूट पड़ोगे ना. तो सेम इज विद द प्यूपिल. अगर इतने टाइम से उसको पैरासिम्पेथेटिक सप्लाई मिल ही नहीं रहा था और अचानक से कोई उसको 0.125% प्रिलोकार्पिन दे दे तो भाई वो तो खुश हो जाएगा और प्यूपिल कंस्ट्रिक्ट हो जाएगा. और सेम यही कॉन्सेप्ट होता है एडी-स्टोनिक प्यूपिल में, दैट द प्यूपिल विल कॉन्स्ट्रिक्ट. इट इज प्रेजेंटिंग टू यू विथ माइल्डली डायलेटेड प्यूपिल बट इट विल कॉन्स्ट्रिक्ट if you are giving cholinergic drops. एंड ऑब्वियसली बिकॉज द शॉर्ट सिलियरी नर्व इज इंजर्ड तो उसका जो एकोमोडेशन रिफ्लेक्स है वो भी स्लो होगा. लाइट रिफ्लेक्स तो एब्सेंट ही होगा क्योंकि वो एफरेंट ही नहीं है उसके पास, है ना. और ऑब्वियसली व्हेन इट विल गो टू सनलाइट देन इट विल बी स्लो रीडायलेशन इन आई मीन when the patient will go in dark, right, in dark you need your pupils to dilate and it will be slow redilation because कब से उसको sympathetic stimulation तो कब का मिल ही रहा है एक्स्ट्रा में, है ना. So even in dark there will be slow redilatation of the pupil and this is what happens in eddy-stonic pupil. So let's come to another condition known as Horner syndrome, and this syndrome is kind of one of the favorite syndromes of the examiner because in some or other way it is always being asked in one or other forms. And so let's see how the patient of Horner syndrome is presenting. So in eddy-stonic pupil we were having the damage in short ciliary nerve also. That means we were having the damage in the parasympathetic pathway, but here in Horner syndrome we are having the damage, we are having the lesion in the sympathetic pathway. So it will be the opposite of eddy-stonic pupil. So this is going to cause anhidrosis, that means loss of sweating, because you all know when you are sympathetically active you will sweat because sweat glands are stimulated by sympathetic cholinergic system, है ना. तो you will have anhidrosis, you are gonna have meiosis, that means constricted pupil, you gonna have ptosis, you gonna have apparent anophthalmos, मतलब ऐसा लगेगा कि आंख अंदर चली गई है. You will be having heterochromia, means different colors of the eye, different color of the pupils, and you gonna have dilatation lag. And this is all the features of Horner syndrome. And let's learn the pathway. Let's see the pathway of the sympathetic system of that is affected in Horner syndrome. So from hypothalamus till the eye there are various areas where it can be affected. So let's talk about the first order neuron which is from the hypothalamus, which is marked in red, from the hypothalamus to the ciliospinal central of Bajweller. अगर ये एरिया में there could be conditions like brainstem vascular lesion, demyelination or syringomyelia. So it can present as Horner syndrome. Very famous Pancoast tumor, क्योंकि see, look at the second order neuron here highlighted in green. From the ciliospinal center, this nerve here is hooking around subclavian artery and then going and supplying to the superior cervical ganglion. ठीक है. And Pancoast tumor, as you all know, here is the lung, and if there is a tumor over here then obviously it is going to affect the sympathetic, it is going to compress the sympathetic nerves, and that's why in Pancoast tumor the patient usually presents as Horner syndrome. Same thing can be happen if you are having a carotid aneurysm. You can have Horner syndrome if you have malignant cervical lymphadenopathy. Then the third order neuron, let's see the third order neuron from here. From the superior cervical ganglion, the nerve is going to the Muller muscle, which is responsible for lifting up the eyelid, and if it is gone, obviously you are going to have ptosis, which is drooping of the eyelid. It is going to supply long ciliary nerve, which is responsible for which is responsible for your pupils to dilate. If it is damaged, then you're gonna present with meiosis. And also because the sympathetic system is also responsible to supply the sweat glands, if it is damaged, you are going to present with anhidrosis. And this is the logic behind Horner syndrome. So in the third order neuron, if you have something like intraoral or retroparotid trauma or cavernous sinus lesion, you can also present with Horner syndrome. And let's talk about the final entity for the day, which is Hutchinson pupil. What happens in Hutchinson pupil? Pupil is the result of the subarachnoid course of the third cranial nerve. So basically what happens when you have any kind of hemorrhage like meningeal hemorrhage, or maybe the intracranial pressure has increased and there is the uncus which is herniating down, all right? So what is happened, the third cranial nerve will be compressed in its subarachnoid course. This happens because the third cranial nerve has subarachnoid course. If you can appreciate this image here, and we have seen this multiple times, that from here it's adding a vespal nucleus, and from here we have the third cranial nerve going here. It lies to it gives the supply to the ciliary ganglion, all right? And if you can see here, this area has a subarachnoid course. This area has a subarachnoid course, and because of this, whenever there is increased intracranial tension, there is going to be compression of the third cranial nerve. And as we know that the third cranial nerve is a parasympathetic supply to the pupil, which is helpful to constrict the pupil. So there are three stages of Hutchinson pupil. The very first stage is when it is just irritating the third cranial nerve. The third cranial nerve is functioning well, but because of the pressure it is being irritated. So you will be having ipsilateral pupillary constriction, because the function of the third nerve is to constrict the pupil, and it is being irritated, so it will constrict the pupil. It will just act like the stimulation. Now the second stage, the bleed is keeping on increasing and increasing. The herniation is keep on increasing. What is going to happen, that the third cranial nerve will be compressed so much that it will undergo paralysis. So in the second stage we have the third cranial nerve paralysis, and it will cause ipsilateral pupil dilation, because obviously, as we know, that third cranial nerve supplies pupil and helps to constrict the pupil. Now it is paralyzed, so sympathetic will take over and the pupil will dilate. So now the third stage and the final stage, where both the pupils are dilated and there will be no reaction to the light, when there will be bilateral third cranial nerve paralysis, right? So look at the image over here. Over here. So in the starting phase of any meningeal bleed or maybe uncal herniation, this can be a very important sign to localize where the bleed is. For example, you are throwing your light here. I mean, if you just observe both the pupil on the left side, you can observe on the stage 1 the left pupil is constricted and the right pupil is normal, I mean, and in the second stage the ipsilateral side will dilate while this side is normal. This is dilated when third cranial nerve will be paralyzed. And in the final stage there is bilateral dilatation of the pupils, and this is what is Hutchinson pupil. There are three stages. The first stage is the irritation, which will cause constriction. The second stage is third cranial nerve paralysis, which will cause ipsilateral pupil dilation, and in the third stage there will be dilation of both the pupils. And this is the last entity, the last topic of the day, which was Hutchinson pupil, and I hope you liked it. And also guys, when just like the rays of the light, if you follow this ray of light, it is going nice, it is going smooth, it is going straight, and the moment you feel that it is going downwards, there will be times in your life that you feel that you are going downwards. Guys, don't worry. Life is just like a convex lens trying to focus you, trying to bring you to the focus and make your picture clear. So never think that whenever you are having a down phase in your life, never ever think that you are going down. Always think that the life is going to bring you on focus and doing everything very beautiful for you. And thank you so much for hearing up till now and tolerating my irritating voice up till now. And I hope you like the concepts, and I hope you like my video, and thank you so much Friends, this is me, Dr. Devesh Bhatt, signing off for the day, and lots of love to everyone. Keep smiling, stay happy.